Assalamu alaikum everyone. My name is Abdulrahman Alabayd and I'm a fifth year medical student. Inshallah, today we'll be discussing psychiatry lectures part 2 for your neurology exam. Alright, so without further ado, let's get started. So first up, we're going to be discussing the schizophrenia, schizospectrum lecture. So it's basically a lecture about psychosis. So psychosis is diseases where there's like multiple things. Psychosis is like someone going crazy. So crazy, you have these weird thoughts, delusions, hallucinations. So whenever this patient's experiencing similar things, we're gonna call it a psychiatric patient, and it falls usually under one of these. However, it's very important whenever you get any patient who has symptoms of hallucinations or delusions, you must always must always rule out substance use. So if a patient comes in to the ER and then he had 1 day onset or a 2 day onset of hallucinations or these abnormal thoughts, then you should always make sure to rule out reversible diseases, because if you can notice something about these diseases is that they're all associated with a prolonged period of time. So like this is 1 month for delusional disorder, schizophrenia is 6 months, schizophreniform is 6 months, less than 6 months. So they're usually associated with a longer time frame, and you cannot diagnose any psychiatric disorder before you rule out substance use, before you rule out medical causes, okay? So now when discussing these diseases, basically we're talking about two types of symptoms: positive symptoms and negative symptoms. Positive symptoms, it's given the name positive because it's adding something new. So this patient is adding new thoughts to life, hallucinations, delusions, or disorganized thoughts or disorganized behavior. So he's adding these new things. Negative symptoms is when you're taking something away. So someone who is living happily, he's energetic, he's doing things, and then when he no longer does these things, these are called negative symptoms, right? So negative symptoms include a blunted affect, which is basically someone who's, emotionless. He's not really giving emotions. His face is, you can't really get anything out of his face. So that's a blunted affect. You have the alogia, which basically he's not speaking much. So he comes into the clinic, you're speaking to him. He answers one word. Sometimes he doesn't answer you. Avolition, which basically he has no activity, he's not doing much things, so he's in his day, he's not doing anything, he's not socializing with others, or he has reduced experience of pleasure. So these are a bunch of negative symptoms. Basically, you can think of it as two things: someone who is creating new hallucinations in life, and someone who's doing less than normal things. And the key symptom whenever you want to diagnose any of the schizophrenia spectrum disorders is that it should be a basically disabling feature. So basically when we're discussing disabling, we're saying that this person, he can no longer function on his own, so he can no longer live normally in his life. So they'd say someone in an exam scenario, they would say someone who's basically having these hallucinations, these abnormal thoughts, and they can no longer keep their job, they have quit their job, they're getting fired, they cannot live at home alone, they're going crazy on the street. So this is basically, they have lost their ability to function normally in life. So this is a key symptom to diagnose the schizophrenia, because if you don't have this disabling loss of function activity, then you should probably look to another diagnosis based on the presentation of the patient. All right. Now, it's another really high thing to know for your exam and even for your USMLEs is that positive symptoms are basically associated with increased dopamine in the mesolimbic pathway. So the mesolimbic pathway, usually the way I do it is that I associate limbic with these thoughts or emotions. So, and dopamine is increased dopamine means increased activity, decreased dopamine means decreased activity. And this even helps you when thinking about Parkinson's disease. So Parkinson's disease has decreased dopamine, and that's why the patient would have less movements. Negative symptoms, there's decreased dopamine, so that's why the patient has decreased or these negative features. All right. And on the other hand, the positive symptoms is increased dopamine because there is increase in this activity. All right. Now, it's important to know that it's an increase in the dopamine and in the mesolimbic pathway. On the other hand, negative symptoms are a decrease in the dopamine in the mesocortical pathway. All right. So keep in mind the pathway and the dopamine change: increased limbic, decreased mesocortical for negative symptoms. All right. Now, symptoms of schizophrenia, as mentioned, this is a picture from your slide. So a patient will have negative symptoms, which include these: positive symptoms, delusion, hallucinations, paranoia, organized speech, and the cognitive dysfunction. All right. They can't focus, they struggle to start, difficulty making decisions, they're falling out on school, they're failing in classes, and so on. Right? Now, this is another picture of the different dopamine pathways, which are really high yield for you to learn. Now, you might not get asked about them in the psychiatry part specifically, because psychiatry, you mainly want to focus on the positive and the negative pathways, or positive and negative symptoms. However, it's important to keep them in mind. Now, we discussed the mesolimbic and the mesocortical pathway, so I'm not going to discuss them again. But the other two are the nigrostriatal pathway, which is basically associated with the substantia nigra, which is responsible for movement. So if you lose dopamine there, you can have the Parkinson's disease. And then the last one is the tubero and fundibular pathway. So it's basically, if you remember from your endoripro lectures, there is a connection between the hypothalamus and the pituitary gland. Now, this connection allows the hypothalamus to release dopamine. Now, this dopamine, when it goes to the pituitary, usually it suppresses prolactin. So that's why, if you remember in endoripro, if someone had an injury to the brain or to the head where there is disconnection of this pathway, there will be no longer dopamine reaching the pituitary. So this entire pathway is going to be lost. As a result, the patient will have a lot of prolactin. There is an increase in prolactin if this pathway is lost. Right? So these are the dopamine pathways. The main two are mesolimbic, increased dopamine for the positive symptoms. Mesocortical, the cognitive pathway, decreased dopamine for the schizophrenia negative symptoms and cognitive symptoms. All right, now the diagnostic criteria. Now, I wouldn't really bother you with learning these, because you would get it from the scenario. If they give you a question stem, you would figure it out that the patient who has these hallucinations or these delusions, usually these are the main two that you'd get, a patient who has hallucinations or delusions, and he has negative symptoms with functional decline, all right? Negative symptoms with functional decline and positive symptoms. Now, if you can see here, they say at least one symptom from 1 to 3. And if you notice, 1 to 3 are your positive symptoms. So in other words, they're saying a patient should have a positive symptoms and negative symptoms. Now, regarding treatment, schizophrenia is treated with antipsychotics, and any psychiatry disorder, if you see any psychosocial interventions, any cognitive behavioral therapy, these are really important whenever you're using them to train or to treat psychiatric patients. But for schizophrenia, it's a psychiatric disorder purely, so you can treat it with antipsychotic medications, and this is where you're mostly using your antipsychotic medications, right? Now, this is another important slide for your exams, even though it seems like it's a little, you're just memorizing it. There's not really much to learn about this, but basically it says what are some good prognostic factors and what are some poor prognostic factors. Now, okay, so a good prognostic factor, if it's acute, sudden onset, if it is late onset at an older age, so acute sudden onset means suddenly develop the symptoms rather than insidious onset. I'm not really going to go through them, so since, it's just a table, you have to learn them. So just focus on maybe the male and the female, the acute sudden onset and the late onset, and the late and early onset, and the slow. This is insidious or the slow onset. All right, so, just read them and get yourself familiarized with them. Now, this slide is really, really important, because basically these three disorders, brief psychotic disorders, schizophreniform and schizophrenia, they have the same group of symptoms, the same positive symptoms, the same negative symptoms, and the same cognitive decline. However, what differentiates them is the time frame. So a brief psychotic disorder, they would tell you that a patient had developed these symptoms maybe 2 weeks ago, and he was hospitalized for a week, and then the symptoms resolved on their own. Okay, so a brief psychotic disorder, less than 1 month, that resolves on its own, right? That's one. On the other hand, schizophreniform and schizophrenia, they don't resolve on their own usually. Schizophreniform is 1 month to 6 months, so anything that's less than 6 months would be a schizophreniform, and if it passes the 6 months time frame, it becomes schizophrenia. So really, the only difference between schizophreniform and schizophrenia is the timing. And brief psychotic disorder is a self-resolving disease, all right? Now, another thing that really gets confused with schizophrenia disorders is the delusional disorder. And this is because you have these delusions. And we said one of the positive symptoms for schizophrenia is delusions. So how would you know that this patient has delusional disorder or has schizophrenia disorder? Now, delusions are basically these false thoughts that you believe they are true. All right, so they're really false things, but you think that they are real and they're true. All right, so this is delusions. However, a delusional disorder has normal functioning, normal daily life. So they would tell you that the patient, he has these abnormal delusions, but he's still able to go to work, he's still able to do school, he's still able to do his life normally, but he just has these delusions. So what are the different delusions? These are the subtypes of delusions. We have the erotomanic delusion. Erotomanic means someone who feels like it's a love type of delusion. So I'd say an erotomanic delusion, if I see someone, I'd say this person loves me so much. So this is an erotomanic delusion. When in reality, this person doesn't even know who I am. A grandiose delusion, I think I am a great guy. I'm the best. So grandiose, I'm, me thinking that I'm the best ever. A jealousy type of delusion, if someone, has in a relationship, he's thinking his wife is always cheating on him. He thinks that his wife is doing all these affairs and things, or husband, for those. Anyways, but basically, jealous type of delusions is when someone who feels this jealousy. Persecutory, I feel like someone is chasing me, right? Someone is chasing me. So this is persecutory delusions. I feel like I'm being tracked, I'm being chased, I'm being attacked. Somatic delusions is that I feel like my head is hurting, my arm is hurting, like some type of somatic disorder or somatic symptoms. I'm feeling symptoms in my body which are really not there. So this is the last type of delusional disorder. So it's important also to learn these types because he might give you a type of delusion and then in the choices it would be these different choices and you have to say which or this example is which type of delusion, right? Now, this is a table this is another disease, schizoaffective disorder. You probably learned it in the previous lecture for schizo or like the mood disorders. So schizoaffective disorder is basically schizophrenia plus mood or mood affect, right? So schizo plus affective disorder. Now, the only difference, however, here, why would you not say this is depression with or bipolar with psychotic features? The way you differentiate these two is which symptom is prominent. So if they said that this patient develops depression most of his days, and some days he feels sad and he gets psychotic symptoms, then this is a mood disorder with psychotic features. But if they say a psychotic patient, the entire time he's hallucinating, and then he got depressed for a while, and then he's no longer depressed, but he's still hallucinating, so the main symptom here is this hallucinations or psychosis. So that's a schizoaffective disorder. So you have psychosis where there's no mood symptoms, right? So differentiated with these. Schizophrenia is not really part of this because the mood symptoms, they're not a prominent feature compared to schizoaffective. Schizoaffective is a patient who completes the criteria for major depressive disorder, a bipolar disorder, and they have the psychotic symptoms. Schizophrenia is a milder type. So there's the milder mood symptoms. They're not really present that much. Now, treatment, I'm not really going too much into the treatment for these diseases because there is a pharmacology lecture for antipsychotics. But basically, you have two types. They have the first generation antipsychotics, your second generation antipsychotics. The difference is that the first generation has more extrapyramidal symptoms, which are the ADAPT, this is a mnemonic, AD for acute dystonia, A for akathisia, P for Parkinsonism, and T for tardive dyskinesia, which are these abnormal movements that the patient who receives antipsychotics experiences. And it's important to note that these symptoms, especially tardive dyskinesia, they're not really limited to the time of starting or the time when the patient starts to use these medications. So for example, a patient who is on antipsychotics, maybe 5 months later, he develops these movement disorders, and this would be a tardive dyskinesia. So these symptoms, they're usually limited or like not limited, but it helps you identify what symptom the patient is having by two things: the actual presentation of the patient and the timing of onset from when the patient has started using these medications. Now, on the other hand, you have your second generation antipsychotics, which have less extrapyramidal symptoms. However, they will have more metabolic syndrome. So metabolic syndrome is a patient who has increased in weight, dyslipidemia, diabetes, or cognitive. And lastly, you have cognitive behavioral therapy. As I told you, usually, or like one of the best treatment modalities for psychiatry is CBT, or cognitive behavioral therapy. Now, these are your types of delusions, as we mentioned. So fixed beliefs, but that are not true, but you think that they are true. However, they are completely false. So these include your persecutory delusions, your grandiose, your erotomanic, your control, you feel like you're being controlled, your referential, you feel like you're being spied on. You have other Now, on the other hand, you have hallucinations. Now, it's really, really important. The main hallucination that you experience in schizophrenia is auditory hallucination. So, and most of the time, if they tell you a patient who is hearing sounds, a patient who hears a voice speaking to him, most likely they're going to be talking about schizophrenia, 99% of the time. Now, other type of hallucinations include visual, where you're seeing things, tactile, gustatory, olfactory, multimodal, and there is other types which we'll discuss when we talk about sleep disorders. Now, another really high yield hallucination that's mentioned on this slide is the tactile hallucination. This is really common with cocaine use. People who use cocaine, they have these tactile hallucinations, right? So this is something to keep in mind for later. All right, now this is from the slides. Now, before I go into that, I just had this slide over here we didn't discuss. So, brief psychotic disorder, as we mentioned, this symptoms with a full return to function less than a month. Schizophrenia form less than 6 months. Schizophrenia more than 6 months. Schizoaffective, where you have these mood symptoms that meet the full criteria of MDD, however, or bipolar. However, there is a large period of time where you have no mood symptoms, but you have these psychotic symptoms. So you have 2 weeks of hallucinations or delusions with no mood symptoms. And lastly, which is delusional disorder, we have normal functioning. It's more than 1 month of delusions with normal functioning. All right, so with that being said, here's a scenario for you to look into it. So, okay, so you can pause the video right now since it's recorded. I'll just go to the answer and I'm going to point out the clues here. So this patient has delusional disorder. And the reason is because you can see that, first of all, the patient here, so the patient here is carefully checking for possible contaminants. He believes that someone here has been poisoning her food. So here, this is his fixed delusion. He has this delusion that someone is poisoning her food or someone is poisoning the food of this patient. So this is a fixed delusion because no one is really poisoning the food of the patient, right? Now, on the other hand, you can notice as well that the patient is still able to live normally. So the patient has no psychiatric history. I can't really find it, but basically, and from the scenario here, you can tell that the patient, he has this fixed delusion. Yes, there it is. She has continued to work. Okay. So the patient has continued to work normally, but she has this fixed delusion. So no affective life. So you rule out schizophrenia and all these disorders associated with it. And since she has a delusion, that's a delusional disorder. Now, on the other hand, we have this patient here who has schizophrenia. Why? Because she is thin, stained clothes, unwashed hair, avoids direct eye contact. These are some negative symptoms. Avoids direct eye contact. She's looking at the ceiling for no reason. Her speech is difficult to follow. So you have a bunch of negative symptoms in this patient. And then here are some positive symptoms. So she is feeling that she has this blessed with the power to save all souls. She's the reincarnation. So these are some delusions, which are some positive symptoms that the patient have. And lastly, you can notice that she has been unable, it's a man. So the man has been unable to hold down a steady job for most of his life. So we met the entire criteria of positive symptoms, negative symptoms, and loss of normal functioning of life. All right. And the only thing that here points it out that it's a schizophrenia, not a schizophreniform disorder, is that it mentions most of his adult life. So most of the life of a 56-year-old man is definitely more than 6 months. And that's why we diagnosed schizophrenia. Now, this disease is a schizoaffective disorder. Why? Because this patient here, he has mood symptoms. Wait, okay. I forgot to pause this part for you guys. Okay, but since we showed the answer, so basically this patient here, he has some psychotic symptoms, but he also has mood symptoms. And if you notice that between his hospitalization, he has periods lasting for several months where the mood is stable, but he continued to hear his voices. So he has psychotic symptoms, but normal mood. And that's why we diagnosed schizoaffective. And last but not least, you can pause the video now. All right, I'll show the answer. It's a schizophreniform disease or disorder. Why? Because the patient here has loss of functioning of life, and at the same time, he has positive symptoms, he has negative symptoms, and it's less than 2 months. All right, so it's less than 2 months of onset. So that's why it's not schizophrenia. All right. So with that being said, all right, we have one more here. Wait. Okay, so you can I'll give the answer right now. So this is a brief psychotic disorder. And now the main clue that points out that it's a brief psychotic disorder is that this patient, his condition improved over the course of several days without any pharmacotherapy. And then he was discharged and returned to work normally. So the patient had some psychotic disorder after some certain trauma or incident that happened to him here. He developed a psychotic disorder that self-resolved on its own. So that's a brief psychotic disorder. All right, so with that being said, this concludes the schizophrenia spectrum disorders. Now let's go to personality disorders. All right. Now, personality disorders. Now, two really important points to keep in mind is that these are some lifelong patterns that usually start early in adulthood and they continue in the life of a patient. And they're not usually diagnosed in childhood because children, as they're growing, you have different type of behaviors in children as they're growing. So we wouldn't really say that this child has a personality disorder unless we see that it's a lifelong pattern that is occurring and moving on with the patient's life. Now, you have three different types or three different groups. You have cluster A, cluster B, and cluster C. And under each one, there's a different group of symptoms that we will discuss. Now, starting off with cluster A, paranoid personality disorder. A paranoid person is a person who thinks that he's being chased. So he's always suspicious, he's hypervigilant, he feels like, he's being chased, he's being targeted by people. So this is a paranoid person. He has a lot of paranoia the entire time. Now, schizoid and schizotypal, it's really important to note down, like usually I'd recommend you write down on a paper, schizoid, schizotypal, schizophrenia, schizophreniform, and schizoaffective, because, they all start with schizo, so it's important to differentiate them, because it's a little bit difficult at the start to differentiate them. Now, a schizoid person is a person who stays away. So the way I think about it is that he's schizoid, so he has the schizo features where he's basically not socializing, but he doesn't have the psychosis. So he only is a person who does not like to socialize with others. So this is the schizoid patient. Okay. Now, and another patient that you need to note is avoidant. So an avoidant person, both of them, they don't have friends. Both of them, they're not socializing. But the difference is a schizoid, he's not socializing because he does not want to have friends. He prefers to be alone. Avoidant personality disorder, avoidant, he does not have friends, and the reason is because he avoids having friends. He wants to have friends, but he's avoiding it because he thinks he's not enough. He thinks he's not good enough to have these friends. So he doesn't really put himself out there. He's not really going out there and making friends because he thinks he has a problem or something bad going on with this person or with himself. So that's why he doesn't have friends. So it's important to differentiate them. A schizoid, he does not want the people. An avoidant, he feels like he does not deserve to have these people, but he wants them. A schizotypal is a person who's basically crazy, magical thinking. So eccentric appearance and magical thinking. Now, the way I remember it is it's schizotypal. So it's a type of schizophrenia where the patient is, schizophrenia, crazy thoughts and hallucinations and delusions. As schizotypal, I think about it as a person who's kind of schizophrenia, but, it's not schizophrenia. Why? Because basically, it's someone who wears random clothes. He's wearing red, orange, yellow, abnormal colors, not normal colors. He has these crazy thoughts. He's going around, clown type of behavior. He's saying random things. He believes random things, but not to the point where you say it's a fixed delusion. So we said in delusional disorder, it was a fixed delusion. This person, he's not having a fixed delusion. He's basically having this magical thinking, magical thoughts going around. Okay. So it's included on the schizophrenia spectrum as well. All right, now cluster B is an antisocial. So antisocial is someone who has no regards to society. So he's against the antisocial, against society. So it's basically someone who is hurting others, who's breaking things, he's attacking people, animals, hitting people, beating up people, and he has no remorse. He doesn't care. He doesn't feel empathy. So this is an antisocial person. Now, it's important to note that there is another disease called a conduct disorder, where a patient has also these similar symptoms where the same presentation. He's hitting others, he doesn't care, he breaks things, he hostile, manipulation, whatever. But a conduct disorder is less than 18 years old. Okay? If a patient comes in with this presentation less than 18 years old, this is a conduct disorder. More than 18 years old, it's an antisocial. And if you remember, we said personality disorders are usually not diagnosed in childhood. So this helps you remember that conduct is less than 18, antisocial is more than 18. A borderline person who's someone borderline. So it's on both spectrums, on the right, on the left. So this person, it's really important to note that he has splitting as a major defense mechanism. Splitting. So sometimes he says, I'm all the way to the right and then all the way to the left. And another important feature of borderline personality disorder is that this type of splitting usually occurs in relationships. So the scenario would be a person who's married, for example, or he has a wife or girlfriend or whatever. In questions of USMLE, that give you a type of girlfriend type of questions. So it says that person, he cannot maintain a relationship. So he's with a relationship one day, he loves his wife so much, and then the next day he's fighting with his wife, he argues with her. A couple hours later, he goes to her, he's apologizing, he doesn't want her to leave him. And then, so he's all the way hating, all the way loving, he's going around between both spectrums. And at the same time, he has different people, people are not going to keep up with this type. So he has several relationships. So in the question stem, they'd say someone who couldn't maintain relationships. Okay, so if we read, it has unstable mood, interpersonal relationships, fear of abandonment, impulsivity, self-mutilation is also an important clue. So this person has multiple suicide attempts. Okay, so this is a really important clue in question stems. And suicidality. Now, treatment for this disorder is CBT, cognitive behavioral therapy, specifically dialectical behavioral therapy. So this is important, and you could get asked about this one in your exams. Borderline dialectical behavioral therapy. Histrionic person is someone who wants all the attention to himself. So he's basically someone very dramatic. He's overacting things. He's trying so hard to get the attention. So attention seeking, very dramatic speech. So for example, someone who says he had some type of argument with his friends, and then he starts crying very dramatically, and he says people are betrayals and bad friends, and he gives you this full-on dramatic speech. So this person has a histrionic personality disorder. So they're either using their attention-seeking dramatic behavior, or they could even use their physical appearance in order to draw attention. They want the attention to be to themselves. Okay? Now, another personality disorder that confused with histrionic is the narcissistic. A narcissistic personality disorder is grandiosity. So the key clue here is grandiosity. So unlike histrionic is being overly dramatic in order to get the attention. A narcissistic, he believes or he thinks that he's the best, he thinks that he's the greatest, and he thinks that he deserves all the attention to himself. So a narcissistic person, in case they do mention attention, so the way that it'd be confused if they mention attention is that histrionic, he seeks attention of people. The narcissistic, he demands this attention. He thinks that he deserves this attention. He thinks that he's greater than all the others and all the attention should be pointed toward him. Okay, so he has a fragile self-esteem. If you don't give him this slight bit of attention, then he goes crazy and he thinks that, he starts talking a lot of things, and he thinks that he really deserves this attention. So that's why he has a fragile self-esteem. Okay, so if you can see here, he demands the best and he reacts to criticism with rage and defensiveness. He gets very defensive. So this is a narcissistic personality disorder. And lastly is cluster C. So an avoidant, we mentioned it earlier. So we said schizoid, he does not want friends, while avoidant, he has hypersensitivity to rejection. So he desires relationships, but he feels he's inadequate. He feels cowardly. He feels that he doesn't deserve to have these friends. So this is an avoidant. Obsessive compulsive personality disorder. Okay, so no two things. OCPD, obsessive compulsive personality disorder, versus OCD, obsessive compulsive disorder. There's no personality disorder here. Now we'll discuss OCD later on. But since it's mentioned here, now its slide is mentioned later on, but I'll mention the difference here. An OCPD, obsessive compulsive personality disorder, I think about it as it's a type of a personality disorder. So the patient is able to live with it. Okay, so that's how I compare it with OCD. Now the key differences here that you need to note is that OCPD is ego-systonic, syntonic, while OCD is ego-dystonic. Okay, so this is one important difference. What does ego-systonic versus ego-dystonic mean? An ego-systonic OCPD is basically, this patient has these obsessive thoughts that are helping him reach toward the goal. In other words, he's a perfectionist. So, for example, someone who needs to repeat or write the same page several times until it's perfect. The perfect handwriting, the perfect words, the perfect, everything is perfect in it. So this patient has OCPD because he knows that he's doing it. He thinks that I must do it perfectly. Okay, so he thinks that I must do it perfectly, so I'm gonna keep on going on and doing it to do it perfectly. So it is aligning with his beliefs and his thoughts, and that's why it is egocentric. On the other hand, OCD, obsessive compulsive disorder, it is ego dystonic. Now, OCD, you see, OCPD has PD, so OCPD is ego systolic, yes. And OCD, there is no P, so ego dystonic. So the D goes directly with dystonic. Okay, now what does ego dystonic mean? It's basically this patient, he also gets these obsessive thoughts to do things. However, these thoughts, they're not aligning with his beliefs. So, for example, a person who washes his hands 10, 12 times. Do you think that he wants to wash his hands 12 times because he doesn't believe that the germs are gone? No, he knows that the germs are gone, but his mind does not allow him to carry on with his life. So his beliefs, he knows that washing his hand one time with water and soap, خلاص, the germs are gone. But his mind does not help him. So his mind is going against his beliefs and telling him, no, you need to go wash your hands again, wash your hands again, wash your hands again. And that's why it's ego dystonic, going against his beliefs. And this is, a part of a different type of disorder. It's not a personality disorder. It's a different disorder. Okay, so this is OCPD. And lastly, we have dependent personality disorder. Now, a dependent personality disorder is someone who cannot live in life alone. So what does this mean? A person who cannot make his own decisions. So someone who basically depends on other. He's with someone right now. He tells this person to do everything for him. Like, what should I pick? What should I choose? Can you make my schedule? Help me, help me, help me. If he lost this person, his first thought would be, I need to find a new person to help me make my stuff. He wouldn't think that, okay, I need to start figuring out things on my own. No, he's dependent. His life is completely dependent on others. So he has low self-confidence. He often gets stuck in abusive relationships because people would abuse him, but he does not have the courage to leave these people because he thinks that he's not going to be able to do things on his own. So, it has kind of a mix of this other personality disorder, such as avoidant, where the patient has this type of feeling of inadequacy. But this person here, he feels like the avoidant person, he does not have friends. This person here, he's stuck in a relationship because he thinks that he's not capable of leaving a relationship. He's not capable of doing things on his own. And if he left it, the first thought would be, I need to find a new person that I can rely on, that I can depend on. Okay? So these are the personality disorders. Now, I hope that's clear. And to make it better, there's a few scenarios for us to read and to discuss these symptoms. Okay? Now, schizoid, schizotypal, schizophrenia disorders, I mentioned this for you to keep in mind when you're thinking about them. Antisocial and conduct disorder, less than 18, more than 18 years old. Avoidant and schizoid, a schizoid does not want friends, and avoidant, he wants, but he feels he's inadequate. OCD is ego dystonic. OCPD, ego systonic. Okay, now this is another table here to summarize it. Now, this is important here, as we mentioned, borderline. We mentioned it merely, basically. Now, the main points where patient has self-damage, self-mutilation, and sometimes is going all the way to the left with his emotions, and then sometimes all the way to the right with his emotions. Main treatment is psychotherapy, dialect, behavioral therapy. Okay, keep that in mind. Now, borderline personality disorder is a recurrent suicidal behavior, mood instability, unstable relationships. A patient usually has history of childhood trauma. Now, this is an important clue in borderline personality disorder, or like something that leads to this disorder is that the patient would have history of childhood trauma. And the main defense mechanism is splitting. Love so much is hating so much. Okay. So let's see. Now, let's read this scenario. We have a 21-year-old man in the emergency department. He sustained an injury during a fight. He broke his nose. He had to do some stitches. His wife says, or his girlfriend says that he always gets angry. He gets paranoid about the way a guy was looking at her. We're not allowed to go back to that bar because he has started so many fights. You see, so we have a pattern right here. Someone who's starting so many fights. Okay. Now, if we see this pattern, if you read through the rest of the scenario, you can find the same pattern First thing you do, look at the age. Less than 18, conduct. More than 18, antisocials. This person is 21, so it's an antisocial personality disorder. Next up, we have a 43-year-old woman comes in here with an injury to her knee. So she blames her injury on bad energy that she was getting from her next door neighbor. She believes she doesn't like her. She thinks she has a sixth sense to detect negative people in her life. She has been able to work normally in life, so she has been able to do her job. So you can rule out schizophrenia disorders. Okay. So the patient, as you can also note, that the patient was dressed in multiple colors. So a patient has crazy thoughts, bad energy. I'm thinking this person has a bad energy. I'm thinking I have a sixth sense, and I'm dressed randomly. What is the first thing that comes to your mind? A schizotypal personality disorder. Okay. Next up, we have a patient here with respiratory symptoms. So he's angry that the patient refused to prescribe antibiotics. And so I'm very busy and must be seen immediately. See, this is an important clue. I must be seen immediately. The other physicians always make time for me. I'm a businesswoman. There's another clue here. If you look down, I'm upset that my daughter, she recently canceled plans to visit in order to help a friend who was in a near fatal motor vehicle collision. So see what this patient here thinks. He thinks that, or this woman thinks that she demands this attention. They think that this attention must be hers. So what type of person has this type of thoughts that he thinks that all the attention must be his? This is a narcissistic person. Okay. Now, next up, a patient comes in with abdominal pain. She has been having stress ever since she broke up with her boyfriend in the relationship. They were together. I did everything to please and make him happy. He abandoned me. I don't know how to go on without him. And then she started crying and discussing how her boyfriend managed her finances. I couldn't go on without him. He helped her apply to her job. Okay. And the first thing that she did was move into a friend that can help her sort things out. So a person who first thought that comes to their mind is I need someone to do things for me. This is a dependent person. Okay. Next up, we have this 22-year-old man who comes in here. He has no friends. He does not date. He has no interest in activities with others. Okay. Now you can note as well that the patient, he makes limited eye contact and he says, I'm not comfortable around people. I don't like it when people try to get too personal and would rather keep to myself. So what type of disorder does the person have? A person who does not have friends because he does not want them. This is a schizoid. Now we have a 19-year-old lady that comes in here because she has very few friends, right? And if you look at what is the reason for her few friends here, patient describes her mood is unhappy but has no change. She says, who would want to be friends with someone ugly like me, someone stupid like me anyway? So this person does not have friends. She wants friends. However, she thinks that she's inadequate to have these friends. So what type of disorder? Avoidant personality disorder. All right, so we have this patient here diagnosed with breast cancer. Okay, she finally agreed. Now the patient here, doctors are always trying to find something wrong so that they can bill. She has no health issues. She does not use tobacco. She lives alone, never dated. The patient appears older than her stated age. She is wearing baggy clothes and her hair is unkempt. She agrees only to a breast examination and asks the physician, why would you need to do anything else? So throughout the examination, her gaze is fixed to the physician. She has a constricted affect. She's focused on the physician. So what type of personality disorder does this person have? Someone who is untrusting, who's thinking that everyone's against them. He can't really trust. So this is a paranoid personality disorder. Untrusting paranoid personality disorder. All right. So person who quit her job while they were on air. Okay. But then I had my own show before, but the station hired a co-anchor. There was no room for me. He became extremely upset last week when he saw an unflattering photograph still featured on the station website. He crosses his arm dramatically And then he says how he quit another job abruptly after his boss told him that he was difficult to work with because he's always trying to take over meetings. He starts going into tears. He says, "My friends don't stab me in the back." So this person here is creating this dramatic scene. He has a loud speech. He's giving you all this dramatic scenery. So this person is basically trying to get the attention. See, even the gestures are exaggerated. So all these symptoms are pointing toward a histrionic person. Okay. Now, this person here, a 19-year-old, the patient says that the professor got annoyed after he requested several extensions for the assignment. He's gone through multiple drafts because he wants to submit something great. Okay. This is important to note that he wanted to do something. So, if you read the rest of the scenario, you'd get the answer of an OCPD because the person is doing something multiple times over and over because he wants to do it. He thinks that he must do it. He's a perfectionist, and this is an OCPD compared to an OCD. Okay, a 33-year-old man comes in here with his wife for marital difficulties. So now my husband is convinced that I'm having an affair with my coworker. He says that he's always demanding to look at my phone. He's always struggled with his temper. He shouts. He's always struggling with his temper. His mood goes up and down throughout the day. His mood is going up and down. Okay. Okay, and then if you read the rest of the scenario as well, you can notice that basically the person here, he says that my ex-girlfriends were all very terrible. They never cared about me. Multiple relationships, multiple car crashes while intoxicated. So you can suspect that this patient here was driving under influence. So suicidal patient, multiple suicide attempts. Basically, the patient here has borderline. If you notice, he then begs his wife not to leave him. So first of all, he was very accusing her of cheating, and now he says, "Please don't leave me." So he's going right and left. So borderline personality disorder. All right, now okay. So let's open up the slides because it had a few questions. So I'll pause this real quick. Okay. Wait. So let me pause the. All right, so let's go back to sharing the. Wait, hold up. Okay. So here, I'm gonna share the slides. Okay, so let's look at the questions the doctor included for your slides. So which childhood experience is most commonly associated with borderline? We said that this patient here has childhood trauma. I mentioned the patient has childhood trauma. Which of the following symptoms is characteristic of borderline personality disorder? They have chronic feeling of emptiness. So chronic feeling of emptiness. The patient has left and right mood, feeling of emptiness, and the patient also. So negative symptoms, formal thought disorder, persistent elevated mood, they're not part of the borderline personality disorder. Attachment instability, emptiness, fear of abandonment. So these are all borderline personality disorder. Which of the following is the core feature? Emotional instability. Their emotions, remember the question said up and down throughout the day. Most commonly demonstrates which relationship pattern? Alternating idealization and devaluation. So one time he thought that the wife was cheating, and then the next time idealizing her, and then please don't leave me. Which defense mechanism is seen in borderline most commonly? Splitting, right and left. The best way to treat it, we said dialect behavioral therapy. Neurobiological finding associated with antisocial. So we said, remember, antisocial is someone who does not really care about others. He's hitting, beating up people, destroying things, and he doesn't really care. So he has reduced activity in his prefrontal cortex. The function of the prefrontal cortex of the brain is to tell you that this thing that you're doing is socially acceptable or not socially acceptable. So if the prefrontal cortex is not really telling the patient that this thing is not socially acceptable, then he doesn't really know. So he just beats up others and he doesn't really care. So his prefrontal cortex is not working. All right. So a person here has borderline personality disorder, extremely distressed. The symptoms reflect a fear of abandonment, okay? Because the patient does not respond, so, his mind goes out, he feels emptiness, fear of abandonment. Which finding is most associated with borderline personality disorder? Again, we said reduced prefrontal function and hyperactive amygdala. Amygdala is the emotional part of the brain, and the hyperactive amygdala means that the emotions are going up and down so much. So it's a hyperactive emotional part of the brain. Antisocial, disregard of rights to the other, we mentioned it. diagnosis, the patient must be at least 18 years old compared to conduct less than 18. Before age of 15, the patient is conduct disorder. Which emotional trait is seen as antisocial? They have lack of remorse, they beat up others, they don't really care, they don't have guilt at all. And then the patient who manipulates, he lies, and he shows no guilt after harming people, he has an antisocial personality disorder. Repeated violation of laws and an antisocial. So these are from your slides. Again, we discussed this. And which treatment has been the best way for managing antisocial? CBT. Whenever you see cognitive behavioral therapy, it's a really important part to treat most psychiatric disorders. So if you see it, it's most likely going to be a choice, cognitive behavioral therapy. All right. Which of the following is a core feature of a histrionic personality disorder? So histrionic, he demands the attention. He has this not demanding. I mean, he wants the attention. He's seeking attention by being overly dramatic. So excessive emotional and attention seeking. And they feel uncomfortable when they're not the center of attention. So remember the person who left his job because another person was hurt, so he felt that he was no longer the center of attention. He was arguing with his boss because he wants to be the center of attention. Which behavior is commonly seen in individuals with histrionic? The dramatic and theatrical behavior. He's crying with gestures and so on. And often they have a speech that's vague and impressionistic. So they're trying to have this impressionistic, they're trying to make impressions and dramatic type of speech. All right, histrionic personality disorder. He has overestimation of relationship intimacy. Remember how he mentioned that friends don't stab others in the back and they're making this dramatic scene and overestimation of relationship intimacy. And which personality disorder is most often confused with it? Narcissistic. The difference is that a narcissistic person, he demands the attention compared to a histrionic person who says that, or he tries to get the attention by being dramatically. Okay, let's go back to our slides now. All right, back to our slides. So now that's concluding our lecture here for personality disorders. Next up is somatic disorders. Okay, now this is a pretty easy topic. Basically, we're dividing it into 3 disorders on this slide and 2 other disorders. Starting off with somatic disorders, somatic symptom disorder. A somatic symptom disorder is a person who comes to the hospital. He says, I have physical symptoms. My stomach is hurting, my head is hurting, my chest is hurting. So he says he has an actual symptom. You do these labs, you do this investigations, imaging, and so on. Everything comes back negative. You find not a single cause for these symptoms. Okay. And now this person, another key feature of this somatic symptom disorder is that this person, he visits the hospitals a lot. So he visits multiple different doctors. He visits the hospitals a lot of times. Every time he does new labs, new investigations, he believes that he has a disease because he has these symptoms. But you do these labs and you find nothing. So this is a somatic symptom disorder. So that's why it's called somatic, because he has somatic symptoms, but there is no cause. Okay, so there is no reason for these symptoms. A conversion disorder is similar to somatic symptom disorder in a sense that the patient has symptoms with no findings, or all investigations are negative. However, 2 primary differences. The first one is that a conversion disorder usually occurs after a recent stressor, which means, like, for example, a close person died, so a close person died, this is 1. And 2 is that the symptoms are not somatic, they're neurological. So, for example, I feel weakness in my arm. So, for example, a close person died and then the patient developed weakness. So he comes to the hospital, maybe you're suspecting a stroke, you do imaging, CTs, and so on, and then you find that the patient has nothing. So this is a conversion disorder. And lastly, illness anxiety disorder. Unlike the previous 2, illness anxiety disorder, a patient doesn't really have symptoms, or if he has very mild minimal symptoms, maybe a small dot on his skin, maybe like a small cough, someone who coughs, a little cough. And then the first thing that comes to his mind is that, oh, I have cancer, I need to go do imaging, I need to go do screening. So a very minimal or mild symptom, and his mind goes to very severe diseases that, they're not really the first thing that comes to your mind. They shouldn't be the first thing that comes to your mind. Okay, so this is an illness anxiety disorder. Someone who has these minimal symptoms and then he worries they have a very severe illness. So he visits and takes lots of imaging, but he has nothing. Okay? So it's like when someone coughs, the first thing that comes to your mind is an influenza, maybe a flu, any type of influenza, normal cough, just a cough. But this person, the first thing that comes to his mind is that I have cancer. Okay? Now, this is a picture from your slide, and it's to note that these diseases are highly associated with generalized anxiety disorder. Now, what's the difference between these diseases and generalized anxiety disorder? Or specifically, illness anxiety and generalized anxiety, because these diseases have an actual symptom. Now, the main difference is that generalized anxiety disorder is someone who has anxiety in his life, generally, throughout the entirety of his life. So, for example, I have worrying that I have cancer. I'm worrying about my money. I'm worrying about my work. I'm worrying about my school. I'm worrying about this. I'm worrying about my diet. I'm worrying about. So he's not only worried about his sickness, he's worried about everything around him: work, life, family, sickness, disease, everything. So this is a generalized anxiety disorder. So his worry is generalized throughout his life. Okay. Now, two main defense mechanisms, which are the undoing and the regression. So learn that these two are the ones that are associated with the somatic symptom disorder. Now I put this picture from your slide. You can read it. All right, so this is the three. The other two are factitious disorder and malingering disorder. The main difference, let's put this slide first. The main difference is that malingering disorder, a person who creates symptoms. So, for example, someone who, maybe takes pills. He's taking his pills and making himself sick to go to the hospital. The difference between the two is that a malingering person is doing that because he wants to gain something. So, for example, I'm doing this because I want to get a sick leave. So I'm taking pills, I'm going to the hospital, or you're hurting yourself to get a sick leave or to get an excuse to get something out of it. Okay? On the other hand, factitious disorder, you're doing it, but you're not really gaining anything out of it. Okay, so for example, I'm taking this pills just because I'm sitting in the hospital and then I'm relieving myself from this worry. So I'm not gaining anything, but just that I am in the hospital now, I can't do anything, I'm sick now, I need to stay in the hospital, and this is a factitious disorder. He's not gaining anything, he's just, wanting to acquire or to live the sick role. Now, a person, he can do it on himself, so taking the pills, for example, make himself sick, or by proxy, which is basically making someone close to him, for example, a mother who makes her son sick in order to take him to the hospital and to receive attention, for example. Keep in mind that you're not looking for external gain. So anything that you do, for example, to gain money, to gain rewards, to gain excuses, this is malingering. If you're just doing it to visit the hospital and then to get the attention you get in the hospital and you relieve your mind from this worry, then this is factitious. Okay? So this is that. Now, if you notice here, the patient here has symptoms. So this is symptoms, and somatic symptom disorder, he has symptoms, and he doesn't really have a motivation for it. So he has symptoms, he thinks they're real, he's doing a lot of tests, but he doesn't really have anything. A factitious disorder and the malingering, they create their own symptoms. Malingering for a gain, factitious, they don't really have a gain. They're just creating the symptoms and forgetting the sick role, or to live the sick role, okay? Now, this is a table regarding that. Risk factors include childhood abuse, childhood neglect, and sexual trauma, and chronic childhood illness or family history of chronic illness. These are really associated with somatic symptom disorder. Okay, an associated feature is multiple providers, repeated testing, and high healthcare utilization. Okay, malingering for secondary gain, okay, to get shelter, for example, to get narcotics. Someone who says that he's in pain to get these narcotics. Factitious disorder, he's just assuming the sick role. He's not receiving direct gain. Conversion disorder, he develops neurological symptoms with neurological symptoms after recent stressor, and investigations and labs are negative. And another thing that you can note here is that it's incompatible with anatomy. So for example, now this is not really the direct example here, but since you probably don't remember peripheral nerve supply from MSK, so I'm gonna give a neurological example. Let's say someone has a stroke in the ACA territory. So remember that ACA is supplying the lower limb, okay? So someone says that he has loss of the lower limb, and then he has loss of the upper limb, for example. Okay? Now, it's not really like that. You will see an example now. But just for you to get it better, someone who says in the lower limb and the upper limb, and now he's saying that he has an ACA stroke. So investigations will show that the patient does not have an ACA stroke, because even anatomically, it doesn't make sense for it to be an ACA stroke, because ACA is for the lower limb, not for the lower limb and the upper limb. Okay, so it doesn't make sense anatomically, and then investigations also would not find this feature. Okay, so neurological symptoms not intentionally produced, they cause functional impairment, and they're often precipitated by psychological stressor. The treatment, CBT, cognitive behavioral therapy. All right, so a scenario here, a 34-year-old woman comes into the emergency with sudden onset neurological symptoms in the left hand. When you look at the pattern of this symptoms, you can note that they are in the fingers and then the entirety of the left hand and the wrist, but there is normal sensation proximal to the wrist, which, you know, anatomically doesn't make sense. And another clue that you can note here that, you know, the patient here had the recent stressor. Now, this is not really a recent stressor because, you know, a patient says that he was lifting a box earlier. But basically, the symptoms, they don't really make sense. Okay, so anatomically here, the clue here that the symptoms, they don't really make sense. You can have other questions where the patient had the recent stressor that developed. Okay, wait. I was reading it wrong. Okay. Okay, wait. So we didn't read this part here that the patient, the symptoms do not make sense, but here you can note, we didn't read the middle part, that the patient was doing this to note an excuse. She wanted to get an excuse from her work. Okay. And she says the doctor should not examine her. Okay, so we should have read the middle part, my bad. But basically, so the neurological symptoms, they do not make sense. So the patient here has neurological symptoms that anatomically don't make sense. And she came to the hospital in order to receive an external gain. She wanted to receive an excuse from her work. So this patient here has malingering. Okay. Now, this person here developed sudden onset leg weakness. You might suspect a stroke in this patient. However, you can note that the husband died recently. So this is now here is the recent stressor in this patient. So neurological symptom with the recent stressor. And then you do neurological examination, everything is normal. You do imaging, everything was normal. But the patient, she says that he cannot lift her leg. So I'm suspecting the patient who cannot lift their leg that, you know, they have loss of movement or motor tone in their leg. But you have normal reflexes, you have normal muscle tone, and when she stands, she's able to stand normally and she's able to work normally. So how does a patient who has a stroke in their leg be able to do this stuff? So it doesn't make sense. And when you associate it with the recent stressor, then you can note that the patient here has conversion disorder. Okay. A woman here comes into the hospital. A month earlier, she was seen for a year-long history of fatigue and leg pain. So she has some symptoms here. She's feeling tired the entire time, sensation of heaviness and aching. All the lab investigations were normal. And she has multiple doctor visits. And every time it's normal. She has a history of childhood ADHD treated with this medication. Okay. She had a history of sexual trauma when she was younger. And the patient, so basically we're saying here that the patient, she has somatic symptoms, she has fatigue, she has leg pain. Every lab investigation was normal, and she had risk factors for developing this disorder. She had childhood trauma. So this person here has somatic symptom disorder. Okay. And lastly, we have a 34-year-old woman coming into the clinic. She is convinced that she has a brain tumor. She visits a lot of the doctors, you do examination, everything is normal, and the entire time she's suspecting that she has a brain tumor. So this person here has a lot of anxiety directed toward this disease or brain cancer. So this is illness anxiety disorder. Unlike generalized anxiety disorder, where anxiety would be general in her life, this patient's anxiety is directed towards cancer or towards her sickness. All right, so that wraps up somatic symptom disorders. Let's go into eating disorders. Now, also, similarly, there's not really much to learn here. A few key clues that you need to keep in mind that would answer all your questions. First of all, is that basically a person here or eating disorders usually occur in younger women Basically, this woman, she has a problem with her self-image. As a result, she has abnormal eating habits. Okay, now three diseases: anorexia nervosa, bulimia nervosa, and binge eating disorder. Anorexia and bulimia nervosa are associated with eating disorder, and after eating, the person tries to do compensatory behavior. For example, the person goes in and runs for 12 hours because she feels that she did something terrible by eating this meal. So she goes to run 12 hours. So this is an abnormal compensation. A person who eats and then immediately after eating she feels regret, so she goes to the bathroom and she induces vomiting. She puts her finger and she tries to vomit. So she's forcing vomit. So this is abnormal. You shouldn't do this when you're eating. You don't normally do this. Okay, so this is the key clue in anorexia and bulimia, which are not seen in binge eating disorder. A binge eating disorder, a person eats a lot and then he feels bad, but then he carries on with his life normally. He doesn't go out and run a whole marathon. He doesn't do these crazy things to make up for this eating. So he just feels bad and then he carries on normally. Okay. So this is regarding that. Another important thing to note is that anytime any eating disorder patient with a BMI less than 18.5, 99.99999% of the time the diagnosis is anorexia. So immediately if you look at the BMI of the immediately if you look at the question stem and you see a BMI less than 18.5, you can just choose anorexia and then read the question stem to make sure it's anorexia. Okay. Now, another part that's really high yield is the clues of vomiting. I don't really mean vomiting as in vomiting, but I do mean vomiting, but at the same time, I also mean it as forcing the vomit. When you put your finger inside your throat, try to force yourself to vomit. Now, the clues here are you see rash and thickness around your knuckles because you're putting your finger in your mouth a lot, so you develop redness and thickness around the knuckles. Parotid gland hypertrophy, because the parotid gland, when you're vomiting, your stomach acids are acidic, so they'd hurt your mouth. And then the parotid gland would start to secrete bicarbonate, so the parotid gland gets enlarged, hypertrophy. Dental erosions, the teeth, it's bone. When you put acid on it, it's going to break down, so the teeth are going to get destroyed. And sometimes also you can get other clues. They're not really related to neurology, but you can remember them in future when you do GIT or your USABLEs or any other exams. So these disorders, since there is vomiting, whenever this patient have vomit, he has high risk of esophageal trauma because you're vomiting. So the esophagus could rupture, could get injured, could get tears in the esophagus. There's going to be bloody vomit. So you're going to learn them in GIT. But keep that in mind in case it comes in your exam. So he has these symptoms here, the parotid gland, dental erosion. These are the most important ones that would, if you see them, you're most likely pointing at this diagnosis. But if you also see someone who was vomiting a lot and then developed this bloody vomiting, then you could also suspect these disorders. All right, now with that being said, this is 99, this is most what you need to learn. The other part is just, facts that we're mentioning. So this is from your slides. So environmental stressors are really high yield causes or triggers for eating disorder: loneliness, criticism, judgment, neurological factors, trauma history. Okay, so anorexia nervosa, BMI less than 18.5. Okay, bulimia nervosa, eating, BMI more than 18.5. Okay, BMI, if it's more than 18.5, you rule out anorexia. Less than 18.5, you diagnose anorexia. So bulimia and binge eating, they have normal BMI, maybe 20, 21, 22, This is what they usually give you. Okay, now the difference, however, is the compensatory behavior. This is inappropriate here, while here there is no inappropriate compensatory behavior. Now, treatment for all three: cognitive behavioral therapy. Number one treatment. Now, in bulimia nervosa and binge eating disorder, you can also use SSRIs, fluoxetine. Okay, now SSRIs, just like we said, CBT are your main treatment for psychiatry. We're also going to add SSRIs because they're really high yield for psychiatry. For me, the way, SSRIs are first line for, I remember it, and SSRIs are first line for GAD, OCD, generalized anxiety disorder. So I say GAD because everything abbreviated, SSRIs. So GAD, OCD, PTSD, anything SSRIs. And حتى bulimia nervosa, binge eating disorders, SSRIs. And specifically fluoxetine from SSRIs, which is the best one that was tested and given for these patients. Now for anorexia nervosa, you're not gonna get asked about treatment, but keep it in mind. And not only you want to give them CBT, you want to give the patient nutritional rehabilitation. Why? Because the patient who comes in anorexic, we said he has BMI of less than 18.5. So this patient is not really eating. So there's two types of anorexia: one that doesn't eat, and one that eats and has the compensatory behavior. Okay, so one that binge eats and then does the compensatory behavior, and the one who doesn't eat. Both patients, they have low BMI, which means they're not getting nutrition in their day. So first step also in treating them is you need to give them nutritional rehabilitation. Okay, so nutritional rehabilitation is really high yield for anorexia especially. And another medication that you can see, which is olanzapine, which can be given. Now, olanzapine, it's an antipsychotic. And remember, we mentioned that one of the side effects of antipsychotics is metabolic disorder, which means weight gain, dyslipidemia, diabetes. A patient who has very low weight, an anorexic patient, they would gain from this medication that increases their weight. However, if it's like a later resort, it's not the first line, because you're giving them an antipsychotic medication which has its own side effects, so you don't really start with it. Okay, now refeeding syndrome. It basically means, as we said, anorexic patient, or even a patient who doesn't really eat well, malnourished patient, if he comes to the hospital and then you start giving them nutritional rehab, sometimes what they do is they give the patient nutritional rehab very rapidly, very large amounts, very large quantities. And this is bad. This creates the refeeding syndrome. So sudden refeeding syndrome, that's where the name comes from. He starts feeding again, but not the correct way to start feeding again. So you have a lot of inappropriately. And the key symptom or the key electrolyte abnormality in refeeding syndrome is hypophosphatemia, low phosphates. Okay? All right. Now, vomiting, electrolyte abnormalities is that vomiting leads to hypokalemia, hypochloremia, metabolic alkalosis. Remember it that the vomiting from the stomach acids going out, so stomach acids, which are HCl, so that's why hypochloremic metabolic alkalosis, because you're losing acid. And diarrhea is metabolic acidosis. So the way I remember it is that both of them have hypokalemia. So just remember, hypokalemia is your number one thing. Don't go to the physiology of it, not really important. Just خلاص, memorize hypokalemia. Potassium is lost. And since vomiting, memorize that vomiting, you're losing acid, so you get alkalosis. Diarrhea is the opposite. So vomiting is alkalosis, diarrhea is the opposite, so it's acidosis. Okay? All right, so, and other clue symptoms in anorexia nervosa or refeeding syndrome, we discussed it, binge eating, restricting type. And one other thing that you need to note, it's like a triad of symptoms that they're associated in female patients who have low BMI and this anorexic type of symptoms. They also develop abnormal menstrual cycles. And this is because they lose their GnRH secretions. Okay, so it's usually a female patient, low BMI, a lot of vomiting, purging behavior if it's the purging type, with the vomiting symptoms, and also amenorrhea, key symptoms. Okay, and in the treatment we discussed it. Okay, amenorrhea is the key symptom. Refeeding syndrome, hallmark hypophosphatemia. Most fatalities due to arrhythmias, electrolyte abnormalities, arrhythmias, and cardiac death. Prevention by slow feeding. Don't give the patient inappropriate refeeding. All right, so we have a look at this scenario right here. So a woman comes in here, a child, 15-year-old person, a child, she occasionally vomits from nervousness. So the patient here, she has very self-consciousness, worries about her imaging, making her stomach look huge, so she's worried about her body image. And then if you look at the BMI, fourth percentile, which in other words, they're saying that she has a very low BMI. So a very low BMI with dental caries, parotid enlargement, scars on the dorsum of the hand, scaphoid abdomen with normal bowel sounds. So these are all clues of a person who is a purging type of anorexia nervosa, because low BMI. On the other hand, we have this woman here. She fainted at home. She's an athlete with a strict diet and exercise regime. She feels out of her control. She craves food, and then suddenly she eats everything in sight. So she eats everything, okay? And then she feels guilty, and she tries to compensate by running 5 new miles every day. or the next day. Okay, so the person here eats a lot and then she tries to compensate by doing an inappropriate behavior, which is basically running. So she's training for a marathon already, and then she runs 5 extra miles just because she ate. So this doesn't make sense. So now we're confused. Is it anorexia? Is it bulimia nervosa? We ruled out binge eating disorder because she has that compensatory behavior. Look at the BMI 20, bulimia nervosa. Next up here, we have a patient who comes in here. I hate the way I look. I try to limit the person, but I end up eating a whole bag of cookies and I'm eating a lot. Okay, so a patient who eats a lot. And you note here that the patient exercise, she does her 45 minutes of exercise a week, but after eating, she doesn't go crazy like the previous lady and does 5 new miles. She does, yeah, she eats, she regrets eating, and then she carries on with her life. I'm doing my exercise, I'm doing my normal training plan, so I'm eating a lot, but I carry on with my life. So this is a binge eating disorder. Okay, so we have questions from your slides, so let's check the slides real quick. All right. So now from your slides, which of the following is a key feature of anorexia nervosa? Intense fear of gaining weight. Okay, so the key diagnostic feature is the patient here has an abnormal body image, scared of their body, so they have this fear of gaining weight. Which electrolyte abnormality is associated with purging behavior? Patient vomits a lot. We said vomiting, hypokalemia, hypochloremia, metabolic alkalosis. So hypokalemia. Enlargement of the parotid gland is seen in which of the following? Bulimia nervosa, anorexia nervosa, binge eating disorder. Mainly with bulimia nervosa, since the doctor here shows green, so bulimia nervosa. Which medication is FDA approved for treatment of bulimia nervosa? We said SSRIs. Which SSRI? Fluoxetine. Okay. Which trait is associated with anorexia nervosa? Perfectionism. Perfectionism in the sense of she tries to look perfect. She has this excessive worry about her body image. So she's perfectionist in the sense of body image worrying. The first line psychotherapy for many eating disorders is CBT, or many psychiatric disorders as well, not just eating disorder. A woman with a BMI of 16.2, anorexia nervosa. See, before reading the question, you see BMI that's low, you put anorexia nervosa. But if you want to look here at the patient, after you put anorexia nervosa, you click it and then you read the scenario. Patient has intense fear of becoming obese and then she intends to lose weight, so she has an eating disorder. We confirm the choice. Which finding is more specifically associated with self-induced vomiting? The Russell sign, which is your calluses on the knuckle, because you're vomiting, you put your finger and that's your knuckles. Again, the hypokalemia mentioned in the previous slide. Which feature distinguishes binge eating from bulimia? The absence of that compensatory behavior. So binge eating, he eats a lot, but then he lives his life normally. Okay. All right. Now let's go back to our slides. All right. Okay. Next up, stress disorders. Now, stress disorders, a few disorders that we discussed. First of all, PTSD and acute stress disorder. What is PTSD? What is acute stress disorder? A patient had a life-threatening trauma. Keep in mind, life-threatening. So someone who had a severe accident, someone who had something that risked their life. Okay, so life-threatening trauma. And after this trauma, they start getting nightmares at night, excessive worrying at night. They have these flashbacks about these memories. Suddenly they get dissociation. So they dissociate from their identity, from their self. They have distress when they're remembering their incident. Anything that reminds them of this thing that caused this trauma caused them to worry a lot. These are your main key symptoms for PTSD. Life-threatening trauma. After that, patient receives nightmare, can't sleep at night, flashbacks. Okay, so if you see hyperarousal, avoidance of the stimuli because it triggers these symptoms, re-experiencing, especially at night with nightmares, patient cannot sleep at night because when they're dreaming, they get these symptoms, and change in their cognition mood. So they feel distress, they have fear. Okay, so if the symptoms occur less than 1 month ago, acute stress disorder. More than 1 month, PTSD. Okay, less than 1 month, acute stress disorder. More than 1 month, PTSD. Treatment, CBT and SSRIs. You see, we said CBT SSRIs, your ABC for treating psychiatric disorders. Now, another medication, now venlafaxine, pointer, okay, venlafaxine is an SNRI, but focused on CBT and SSRIs. Prazosin is an alpha agonist, I think, or alpha blocker, I'm not really sure, but it's a medication that can help the patient sleep at night. So CBT SSRIs during life, or like whenever the patient has these symptoms, but to sleep at night, the patient can use prazosin to help them sleep at night. So focusing the medication that mainly focuses on helping them sleep is prazosin. Okay, acute stress disorder is the same thing. However, it lasts less than 1 month. So that's why you just treat it with therapy. You don't really need to give the patient medication because it resolves usually within 1 month. Now you need to note that there is also adjustment disorder. Adjustment disorder is a patient who had a stressor, but it's not really life-threatening. The patient doesn't really have these nightmares and flashbacks and dissociation. And now this is the diagnostic or DSM criteria for adjustment disorder. It occurs within 3 months of the stressor and it resolves within 6 months. Okay? If it doesn't resolve within 6 months, then you rule out adjustment disorder. But I hope you understood PTSD and acute stress disorder from this part. Okay? Now coming up to ego dystonic or OCD, we discussed it earlier, so I'm just going to go over it briefly here. We said it's ego dystonic. You have these obsessions, these thoughts in your mind that you get these repetitive thoughts of something. The only way for you to relieve these thoughts is by doing an action. So these thoughts cause you anxiety. The only way to reach relief is by doing these compulsions or these behaviors. Okay? And as a result, you get, it comes back and over and over and over and again. Okay, so ego dystonic, basically we said, is that your mind does not believe that you need to do these things, but you're doing it in order to relieve your anxiety. Okay, so a germaphobe, for example, he thinks that, we mentioned earlier, you don't believe that you need to wash your hands 17 times to get rid of the germs, but your mind is telling you that unless you do it, you're not getting rid of the germs. Unless you do it, you're not getting rid of the germs. So you're washing your hands over and over and over again. Now, some types of OCD include body dysmorphia, which is the patient here, he's preoccupied with, for example, some minor appearance or some minor thing in his face or in his physical appearance. So, for example, someone who has a little pimple on his face, and then the entire time he gets this obsessive. So what is the obsession here? What is the thought? His thought or the obsession here is that this little dot on his face is making him ugly. So his compulsion is over and over and over again, he's looking into the mirror, for example. This is a body dysmorphia. So a patient who he's normal, he looks great, he has nothing wrong with him, he or she, and they look great. But they get this repetitive thought of that there's something wrong with them, so they have this action of looking into the mirror a lot. And another type of OCD is a trichotillomania, which is someone who has this intense thought or urge to pull out the hair. So they start pulling out their hair in order to relieve it. But it's not normal, As a normal patient, nobody thinks that it is okay for themselves to pull out their own hair. But this type of OCD, he cannot relieve himself unless he pulls his hair. So this is an OCD, okay? Ego dystonic, that's where it comes from. All right, so this is here for acute stress disorder, less than 1 month, similar symptoms to PTSD. The difference is that more than 1 month in here. This one you treat with CBT. This one you treated with SSRIs and CBT or prazosin for sleeping. Okay, you can read the symptoms. OCD, obsessive thoughts, repetitive thoughts or urges such as the hair pulling urge or images but dysmorphia. And then you get this compulsion. So you must do the action in order to relieve yourself. It's time consuming and it causes significant distress because it's ego dystonic. Treatment, SSRIs and CBT. You remember how we mentioned that borderline had dialectical behavioral therapy as the main CBT? OCD has exposure and response prevention as the main CBT. So this is another CBT that you really need to learn or to remember in its thing. Okay, scenarios. Let's check sure the recording is going. Okay. 32-year-old woman coming in here feeling anxiety for 2 weeks. Okay, 2 weeks. Now she's basically crying and difficulty concentration, difficulty sleeping at night because she's awakened by episodes of palpitation and shortness of breath. Okay, she's awakened at night. She was mugged 3 weeks ago. So the patient had a life-threatening trauma 3 weeks ago, less than 1 month. So it's not PTSD. As a result, it led to disruption in her sleep, in her lifestyle, in her ability to live. So here they basically mention you the patient getting nightmares. She's awakened at night, palpitations and sweating and scared, and she has nightmares. Okay, and she can't sleep at night. Overall, the patient here has acute stress disorder. If you read the rest of the scenario, she's an acute stress disorder because less than 1 month. Now, this patient here wakes up at night again in a state of panic. Similar presentation as the previous patient. And the patient here, she had 3 months ago, she filed for divorce because the husband has violent behavior. So, husband violent abuse of the patient here. So that's threatening trauma. 2 months and nightmares are seen. Okay. Patient jumps when the door is closed. So this is started, So we mentioned here that PTSD, the patient has hyperarousal. Okay, so hyperarousal. Something happened, she gets shocked, she gets scared. So this patient here has PTSD for more than 2 months. This patient comes in worrying all the time. It was manageable when she was able to work from home. But since coming from home, she's overwhelmed. She's basically rehearsing to find the right words to say, repeatedly edits until they're good enough. Okay, maybe this person here is perfectionistic, so maybe it's OCPD. So let's keep on reading. But here, see, the patient here spends 1 to 2 hours making sure all the appliances are unplugged. I know it sounds crazy. I constantly worry. So what are your key clue here? Is that the patient here spends a lot of time checking that the appliances are unplugged. Like if you unplug it once, you can, if you want to leave your house right now, you can unplug everything in 5-10 minutes. Okay, so that's one thing. So it's wasting 2 hours of her day unplugging things. So she's checking over and over and over. Another clue here is that she can't concentrate. She sounds crazy, so she does realize that this is not normal. So she thinks that she agrees and acknowledges the fact that her thoughts, her actions, her behavior is not normal, and as a result, you can say that this is no longer OCPD. She has OCD, ego dystonic behavior, that she says is not normal. All right, so slides has some questions. Let's check those real quick. All right. So OCD patient has an ego dystonic behavior. He's doing it to reduce the anxiety. He's not doing it because he's happy doing it. He's reducing anxiety. So he does not feel okay unless he does these actions. All right, so because the loop is overactive. Okay, so repetitive thoughts and behaviors. All right. So we have this woman here who has recurrent thoughts and washes her hand repeatedly. So this is an OCD. Okay. Which of the following best describe the obsessions in OCD? Obsessions are the thoughts. So they are your unwanted thoughts, your intrusive thoughts, the unwanted thoughts. Okay? Unwanted, because this is the ego dystonic part of it. They're unwanted. Okay. Compulsions are the actions that you're doing. Why are you doing it? To reduce anxiety. What is the first line treatment for OCD? CBT, cognitive behavioral therapy, especially exposure response prevention. What is the first line pharmacological treatment? SSRIs, ABC, SSRIs. Which brain circuit is implicated in obsessive compulsive disorder? So the brain circuit here is the cortico-striato-thalamocortical circuit. Okay, so just there in this pathway here. Okay. Which feature helps differentiate OCD from psychotic disorder is that in OCD, the patient here has insight. Okay, so in psychotic disorder, you get a schizophrenic patient, for example, he says that he's hearing voices. You tell him the voices are not real, he's not going to say the voices are not real. He says, no, there are voices, I'm hearing voices. While an OCD patient, remember in our scenario, he said that you might think that this is crazy what I'm doing. So the patient has an idea that what he's doing is not all right. So he has insights into his thoughts. A patient spends 2 hours distressed. Which criteria for OCD is met? Time-consuming behavior. So the behavior, really important for OCD, is that it's time-consuming and ego dystonic. Common obsession, fear of contamination, washing your hands a lot. Which statement about OCD is true? Symptoms are ego dystonic. All right, we mentioned all these, so let's go back to our slides. All right, so next up is sleep disorders. Now, sleep physiology. This is high yield. Might get questions about it. The whole point of sleep physiology is that at night, your hypothalamic suprachiasmatic nucleus releases norepinephrine into the pineal gland, which releases melatonin. Melatonin is your hormone for sleeping. More melatonin, you start sleeping, you go to sleep, you sleep for a long time at night, okay? So one of the slides, the doctor mentioned that elderly people have decreased melatonin, and that's why elderly, your grandparents, you might have noticed, they don't really sleep a lot. They might sleep early on at night and then they wake up at the middle of the night. Their sleep is, it's not a constant long 6, 7, 8 hours of constant sleep. They sleep 2 hours, they wake up, sleep and wake up. And it's because they have low melatonin. Melatonin is the hormone of sleep. Okay, and also some medications that people sometimes get pills of melatonin so that they can help them sleep. Now, this pathway is important to create our circadian rhythm. Circadian rhythm is basically at night you have different functioning of your body. So your wake time hormones, your night hormones, these are all controlled by your circadian rhythm. And this circadian rhythm is controlled by your hypothalamus and the suprachiasmatic nucleus, right? So other hormones that are released at night, which are important for growth, are your ACTH and growth hormone. And that's why they tell you when you're younger to sleep more at night, because at night, that's where you have your more growth hormone to be released. All right, now in this slide here, the doctor is basically mentioning that during your day, so you wake up here at 9 a.m., and then you're doing your activity throughout your day, right? What you're doing throughout the day is that you're building up adenosine. Adenosine is built up from the breakdown of ATP, energy, when you're doing your life, you're working, whatever, you build up adenosine. The more adenosine you have, the more tired you are. And that's how coffee works. Coffee basically blocks the adenosine receptor. Okay, so caffeine, it blocks adenosine receptor because adenosine tells the body that you're tired. So if you block this signal, the body can no longer understand or no longer figure out that you're tired. And that's how coffee works. Okay, so basically adenosine triggers that. Melatonin release is the one that controls sleep. Here's the melatonin. With aging, you have decreased melatonin. All right, now this here is a really important table for sleep disorders, okay? Now, personally, I just memorized this mnemonic. Bats drink blood at night. BATSDB. So it basically here tells you, now what you need to do, what I did, memorize these stages, awake eyes open, awake eyes closed, N1, N2, N3, REM sleep. And then apply the mnemonic. B for beta, alpha waves, theta waves, sleep spindle and K complex, delta waves, deepest stage of sleep, and beta waves again. Okay? So, you can memorize this to that one, but it's easier if you remember awake eyes open, awake eyes closed, and 1 and 2 and 3 and REM sleep, and then memorize bats drink blood, and then write it down on your exam paper, on your scratch sheet, and then match this with this, this with this, this with this, and you get it up. Okay? And you figure it out. Now, what are some important clues other than this part? So this one is important, the waves, okay? Other thing that you need to get from this table. Another thing you need to get from this table is that stage N2 of REM sleep is your longest phase of your sleep. It occupies 45% of the sleep cycle, okay? What's another thing that you need to know? N2 has bruxism, which is tooth grinding. So 2 for tooth grinding. N3 has sleepwalking, night terrors, and bedwetting. Okay. Now, before you learn it, to make it easy, because see, you have two different things right now. You have night terrors, you have nightmares. Okay, what's the difference between night terrors and nightmare? Let's look at REM sleep. Okay. Now, REM sleep, I'll discuss it first and then we'll go back to N3. Because if you learn REM sleep, you finish it out, what's not REM is going to be N3. Okay, REM sleep is basically referred to as the rapid eye movement sleep. It's where the eyes are rapidly moving during sleep. It's important because this is, if you look here, it's the beta waves. So your brain has the highest function, highest activity of your brain. Another important feature of REM sleep is that you have body paralysis. So we said you have body paralysis, you have your beta waves, you have your rapid eye movements. And lastly, you get your dreams and nightmares during REM sleep. dreams, and nightmares during REM sleep. How to remember it? Let me look it here. REM sleep for remember and nightmare. Why is this important? It's because nightmares occur during REM sleep, and when you wake up, you say, I had a nightmare. You remember the nightmare. Okay, so nightmares, you remember them. And if you compare that to night terrors, they occur during N3. See, that's why I told you remember REM sleep, because REM, REM, yeah. And then you can cross out the N3 night terrors. So N3 night terrors, you don't remember it. Okay, so you get night terrors during night, but you wake up, you don't know that you had these night terrors. Okay. Now, other features of REM sleep include the erection that occurs at night. N3 has the bedwetting, sleepwalking, and the night terrors that occur. All right. So, with that being said, this is the most important parts in here. Other things, and if you had memory capacity to learn, you can learn these parts. And older adults have decreased REM sleep, decreased N3. They have less deep stages of sleep, more sleep latency, and more early awakenings. Sleep latency is basically referring to the fact that the time it takes them to go to sleep, at the time it takes them to fall asleep. In depression, you have decreased REM latency, so you go into REM sleep immediately. The time it takes you to go to reach REM is less, so you go into REM sleep immediately. A depressed patient is during REM sleep most of the time. So you can think about someone who's depressed, he's dreaming a lot at night, and then he wakes up with his dreams. Okay? With repeated nighttime awakenings and early morning awakenings. Narcolepsy, we'll discuss in a second. Narcolepsy is disrupted REM sleep cycle. Okay, so what is narcolepsy? The REM sleep is disrupted. So you have low REM latency. Basically, the disruption in the REM sleep cycle causes the person, you're going through your day normally, suddenly you fall into REM sleep. Suddenly. So if I say you fall into REM sleep, what do I mean? Muscle paralysis, dreams, nightmares, hallucinations, you're seeing things, dreams, and you're paralyzed and you fall asleep. So this is what I mean by low REM latency. This is narcolepsy. All right, so another thing here is that patients who takes these medications, alcohol, benzos, barbiturates, these medications are depressants. What depressants mean? They basically shut down your CNS. So these medications, however, they decrease the REM sleep and N3 sleep. So someone who has, he had a lot of to drink a previous night and they fall asleep, they fall off because they're drunk, they black out. A blackout is not really considered sleep. Why do they wake up tired after blacking out? Because they didn't get into their deep stages of sleep. The deep stages of sleep are the ones where you actually recover your body. Okay? Benzos are useful for night terrors and sleepwalking by decreasing these. Because if you don't go into the N3 and your REM sleep, then you're not going to get your night terrors, right? Okay, so a sleep terror disorder is a disorder where the child is screaming in the middle of the night. He saw this very scary thing, and then you wake up the child, you ask him what happened, why are you screaming? He has no idea that something happened. Okay, so this is the sleep terror compared to REM sleep where you remember it. All right. Okay, so insomnia is basically you can't fall asleep at night because your sleep. Now, the main reason insomnia occurs, this is not really part of your exam, but this is just extra information. The main reason insomnia occurs is because you have disrupted your circadian rhythm. And so the best way to fix insomnia, if you're someone who's suffering from it, is try to develop better sleeping hygiene, better sleeping habits, less screen time at night, no coffee after a certain time, fix up your sleeping hygiene, and that's how you fix insomnia. Okay. And that's now a disease mentioned by your doctor, even though it's not really related to sleep disorders, but it's something that occurs at sleep. It's obstructive sleep apnea, which basically means what it is that someone who's sleeping at night, and suddenly at night they're sleeping, they're snoring. Okay, so they're snoring. This is a very high age clue. Snoring at night, suddenly they stop breathing while sleeping, and then they start breathing again. So they wouldn't report that. Maybe they have a spouse, a wife with them, The wife comes and she says that my husband is sleeping at night, but suddenly he stops breathing, he snores loudly. These are clues at night. In the morning, he's sleepy, he's tired, he couldn't sleep well. Why? Because when he was sleeping, he wasn't receiving well oxygenation of his body. His blood wasn't oxygenating well, so his brain wasn't receiving good oxygenation. So he's sleepy in the morning. He also develops systemic hypertension and pulmonary hypertension, and this has to do with less oxygen coming into the body. But I'm not going to go into the physiology of it because too deep. خلاص. Just know that this patient has daytime sleepiness, and if they happen to actually watch complications, then it's hypertension, pulmonary systemic. How is it diagnosed? Polysomnography, which is basically when the patient goes to sleep, they do tracking of his sleep cycle or his breathing during sleeping, and they basically they monitor his sleep. And the treatment is CPAP, which is basically opening up the airways where the patient is sleeping at night. The main issue that occurs with obstructive sleep apnea is that when the patient sleeps, they obstruct their airways. As a result, they no longer breathe, and as a result, they get these symptoms. So a CPAP opens up these airways so that you don't get these symptoms. The two most important causes of these diseases, if it's an adult, it is due to obesity. If it's a child, it is due to enlarged tonsils, adenotonsillar hypertrophy. Okay? So if it's adults, it's due to obesity. All right, so this is another picture of obstructive sleep apnea here. Basically, normal breathing, you have the airway clear. Here, you have a disruption in your airways. All right, REM sleep disorder. What is REM sleep disorder? We mentioned that REM sleep is when a patient has these nightmares at night that they remember. So they're having these dreams, they're nightmares, they're remembering them, right? And the key feature of REM is that you have muscle paralysis. In REM sleep disorder, you have your nightmares, you have your dreams, you have everything. However, you don't have your muscle paralysis. So if you see here, she's sleeping, she's dreaming, but she's acting out her dreams. So for example, maybe in her dream she's running, she's doing something, she's acting out her dreams. So this would be the patient has no idea that she's doing that. So it's reported by someone close to the patient. So someone said that, oh, this person, he is sleeping at night and then he starts kicking and hitting everywhere, but they have no idea. Okay? Why? Because they have no paralysis. This is REM sleep disorder. It's not really high yield for you right now, but it's important for later on to learn. But REM sleep disorder is usually associated with Lewy body dementia, which is a type of Parkinson's disease. Now, narcolepsy, as you mentioned, disrupted REM cycle. As a result, this person has low REM latency. So as a result, suddenly during the day, they fall into REM. If they fall into REM, they start getting dreams. Dreams are hallucinations if you're awake. So these are referred to as the hypnagogic and hypnopompic hallucinations, which are your hallucinations as you're falling asleep and as you're waking up. These are your dreams, actually. Okay, so these are your hypnagogic and hypnopompic hallucinations. Another thing is the sleep paralysis, which is basically when you're going to sleep or when you're waking up from sleep, suddenly you feel paralyzed. Okay, because you're still in your REM type of paralysis. Cataplexy, where you have sudden loss of muscle tone triggered by strong emotions. And sudden sleep attacks, usually these two occur together. Suddenly falling asleep, paralyzed, they were triggered by strong emotions, and this is because of the REM paralysis. Okay? Why does it occur? Pathophysiology, loss of orexin or hypocretin production in the lateral hypothalamus, leading to dysregulated cycle. And treatment is good sleep hygiene, daytime stimulants to prevent you from falling asleep, and nighttime sodium oxybate to help you fall asleep. All right, so this is basically still psych and spectrum narcolepsy symptoms. You get all these abnormal things: sleep paralysis, insomnia, sleepiness, cataplexy, hallucinations. All right, so this is it regarding sleep disorders. It's pretty straightforward, yeah. All right, now next up is substance abuse lecture. Now this might seem like a pretty tough lecture. Now when I did the slides, my main reference was psychiatric slides, which had mention of 3 or 4 substances only. These are the ones that I included. But now I'm remembering that maybe you had in pharmacology another mention of more substances and more drugs. So if you have questions regarding those, you can let me know. But regarding the ones mentioned in psychiatry slides, these are the ones that I'm mentioning here. Okay, so two important things that I want you to know. Based this slide, learn this slide, it makes everything as easy. You have three types of substances. Stimulants activate your sympathetic nervous system. Why we call them stimulant? Because they activate the sympathetic nervous system. Depressants, they shut down the sympathetic nervous system. And hallucinogens, which make you have these hallucinations. Okay? So, if you're overdosing on your stimulant, you have increased activity of the sympathetic nervous system. If you have withdrawal symptoms, you'll have decreased activity of the sympathetic nervous system. Okay? And vice versa with the depressants. Increased activity and decreased activity. Now, this is one part. Next thing you might ask, and okay, how would I know that is this person overdosed on a stimulant or withdrawing from a depressant, or overdosing on a depressant or withdrawing from a stimulant? Because they both have the kind of similar symptoms. Here, the main way to tell, first of all, usually there are key features associated with each drug, whether it's an overdose or a withdrawal. So you need to look for these key features if you find them. And then another clue is look at the question stem. If he says that the person was partying all night and then developed the symptoms, you're more likely thinking about someone who was partying and doing drugs or alcohol. Alcohol is with the depressant. So I mentioned alcohol because it's part of these substances abuse. So someone who was partying, they usually overdose. So it's over here. Someone who has been hospitalized and then maybe one day after their stay at the hospital, they developed symptoms, then you might suspect withdrawal. Why? Because the one who is hospitalized, he doesn't have access to his drugs or to his alcohol. So since he's dependent on it, a key feature of substance abuse is that you're depending on it, you're developing tolerance to it, you have your withdrawal symptoms. So if you're hospitalized, you don't have access to this medication, and since or these substances, and since you're dependent on them and you don't get them, then your body is gonna go into overdrive, or basically, if it's a stimulant, have decreased activity. If it's a depressant, you have increased activity. Okay. And another key clue that really is very high yield, take it with you from now on and going forward, any examination that you're gonna do that has to do with substance abuse, always check pupil size, and not just substance abuse. Anytime you see a psychiatric question, before you diagnose any psychiatric disorder, always rule out substance abuse. And the best way to rule out substance abuse is by checking the pupil size. Why is it through this? Because pupil size are affected by the sympathetic nervous system. Sympathetic nervous system causes a dilation of your pupils. Less sympathetic or more parasympathetic causes constriction of your pupils. So always look for pupil size to know whether you're talking about a stimulant, which would cause it to be dilated, or if you're talking, if you see change in pupil size in a psychiatric question, 99% of the time, you're talking about substance abuse. All right, now, road to the brain. The main thing to note here is that if you inject them IV, it's the fastest route to the brain. Why? Because IV immediate to the blood, immediate to the body. Okay. However, it has association of risk of infections. IV drug users have high risk of HIV, hepatitis C infections, endocarditis. All right. Now, okay, addiction, the path or the nuclear biology of it is that the main reason of it is that you have dopamine. Dopamine is your reward hormone. When you're addicted to something, you stimulate too much dopamine. So you're overfrying your dopamine brains. You're creating too much dopamine in your nucleus accumbens. And as a result, the brain needs to reach this high dopamine level. And the only way to reach it is by taking more of these substances. And that's the main neurobiology of addiction, is through dopamine. All right. Now, let's start by depressants. The main two mentioned in psych slides and even in your everywhere. The main two are your alcohol and benzos and barbiturates, but I put alcohol and benzos because they're usually more associated with each other. Okay. Now, forget benzos. Okay. I mentioned benzos because it's a depressant as well. It has similar presentation as alcohol. But let's focus on alcohol right now. Alcohol is a CNS depressant. Okay, so if you're overdosing, you have CNS depression. And the way it's doing it through increased GABA. This is a note for your pharmacology. You're probably going to get a question about benzos and barbiturates, the difference in the mechanism of action. One of them was for duration, one of them was for frequency. I don't really remember which was for which, but look it up and make sure you remember which benzos, which increases GABA duration, and which increases the frequency. Now, regarding alcohol, the key or the more questioned part of it is the withdrawal symptoms. So we said it's a depressant. So someone who has been hospitalized and 2 days later after hospitalization, they developed anxiety and tremor and sweating, suspect alcohol withdrawal. And if they tell you in the question stem that he's an alcoholic, and they made it easier for you. They told you he's an alcoholic and he's no longer taking access to alcohol. Okay? Now, why is alcohol withdrawal symptoms high yield? Because you have something called delirium tremens. To keep it simple, and the way I remember it, to not complicate you with this table, anything less than 48 hours is not delirium tremens. Anything more than 48 hours is delirium tremens. And both of them have relatively the same symptoms. So if I tell you someone is hallucinating at less than 48 hours, it's not delirium tremens. It's alcohol withdrawal before delirium tremens, okay? If I tell you someone is hallucinating, the same hallucinations, after 48 hours, it's delirium tremens, okay? So keep this cutoff time at 48 hours. Now, complications of alcohol overuse or alcohol use include liver disease, cirrhosis, pancreatitis, cardiovascular disease, which is a high yield cause of death, and a very high yield disease in alcoholics is thiamine deficiency, vitamin B1 deficiency, which leads to Wernicke-Korsakoff syndrome. Okay, Wernicke-Korsakoff syndrome, very high yield. Okay. Now, what is the triad? Probably you wouldn't have to diagnose a Wernicke-Korsakoff. It's probably going to tell you that the patient is alcoholic and develops symptoms. Wernicke, what should you do to treatment? The thing that you're more likely to get asked about is this part on the right side, is the treatment of Wernicke-Korsakoff. But I'm going to mention this part. Wernicke is reversible triad. In an exam, they'll give you the triad: ataxia, confusion, and ophthalmoplegia or nystagmus. The way I remember it is that Wernicke, the first where are you, where? So ataxia, the body is going around randomly trying to find where. The brain is confused, trying to think where. And then the eyes are looking left and right, nystagmus, trying to see where. Okay, so that's the way I remember it. Wernicke, so where? The ataxia, the nystagmus, and the confusion. Over time, it becomes irreversible deficiency known as Korsakoff syndrome. The key features here are memory loss, and confabulation. Confabulation means the patient starts making up things. And what happens in Korsakoff? There is atrophy of mammillary bodies. Now, this might be important. If you might get asked about this one, so learn it. Even if not in psych, maybe in neuroanatomy. The treatment is thiamine, then glucose, or B1 before glucose. I mentioned this because it's two mnemonics that people use to remember it. Is that thiamine, the TH, then glucose, or B before glucose, so B1 before glucose. Always give thiamine before glucose, because if you give the patient, someone comes into the hospital, alcoholic, and they give him glucose or nutritional support without thiamine, the Wernicke symptom will get exacerbated. So if someone comes in, he receives glucose or nutrition, IV nutrition, and then he has ataxia, confusion, ophthalmoplegia that are more severe, what is the patient having here? Wernicke encephalopathy. What is the first thing you need to do? Give thiamine. Give B1, because it can worsen Wernicke's, leading to a reversible Korsakoff. Fetal alcohol syndrome refers to that if a pregnant woman is taking alcohol while she's pregnant, she has the child which develops fetal alcohol syndrome. Intellectual disabilities, small face. Key symptoms include, or key feature include, a thin upper lip with a smooth philtrum. The upper part is very smooth, thin upper lip, very thin compared to the lower lip, and small head, small eyes. Everything is small. The way I remembered fetal alcohol syndrome, everything is small. Small lips, small this, thin, small face, small eyes. All right. Now, alcohol and benzos. This is why it's important. Why I mentioned benzos. It's because withdrawal symptoms. So when I'm saying alcohol withdrawal, is the withdrawal symptoms of alcohol, since it's a depressant, the withdrawal symptoms are going to be sympathetic overactivity. Okay? Someone who has sympathetic overdrive, how do you treat it? You must suppress the sympathetic nervous system. Would you give the patient alcohol? No, this is not ideal because alcohol is bad. So what you do is you give the patient benzodiazepines because both of them have similar effects of CNS depressants. That's why you give benzodiazepines, which are going to be relieving the withdrawal symptoms, which are suppressing the CNS. On the other hand, if someone is alcoholic and he wants to quit alcohol, you give him two medications. First line, naltrexone, which is an opioid antagonist, which reduces the cravings, acamprosate, which is the glutamate antagonist, which also helps reduce craving. So these are the first line medications. The patient takes it and then he no longer wants alcohol. It helps him to quit alcohol. And the second line medication is disulfiram, which basically creates unpleasant symptoms. And that's why it's second line, because it causes these adverse effects. The way it causes the person to quit alcohol, it's by making him hate alcohol, because it gives him all these terrible symptoms. So the patient, he takes this disulfiram and then he drinks a little bit of alcohol. So it's no longer going to be broken down, and he gets a lot of symptoms from very tiny bits of alcohol and disulfiram. So first line, naltrexone and acamprosate. Anyways, opioids. All right, so opioids is a CNS depressant. Okay, so decreased consciousness and somnolence, similarly, both are found in alcohol and opioids. I told you there are key features for each drug or substance abuse. Opioids, the key features are respiratory depression. So if a patient comes in here with a respiratory rate of 5 or 10 or 7, you should suspect opioids. If a patient has decreased consciousness and his respiratory rate is 20, 25, it's not likely to be opioids, because opioids cause respiratory depression. Another feature is constipation, but it's not really your key go-to clue when you want to diagnose overuse, but it's important when you're diagnosing withdrawal. Okay, we'll talk about it in a second. And lastly, it's meiosis, or constriction of the pupils. Okay, so opioids cause these. So a patient who overdosed on opioids, how do you treat it? By naloxone. Now, a way people remember it is that, let me check up the pen real quick. A way people remember is that, in the naloxone, the O for overdose, whereas you have naltrexone for relapse, okay? So naloxone and naltrexone here. Let me clear up that. Clear. Okay, so that's regarding naloxone and naltrexone. Now, okay, so you figured out the symptoms of overdose. Now, withdrawal symptoms, the first one that you want to look for to is mydriasis, which is dilated pupil. And other symptoms here are your pooping, your peeing, your tearing, your NEUs. Why I put them all together here? Because the way I remember it is that opioids withdrawal, fluids are coming out everywhere from your body, from your nose, from your eyes, from everywhere else. Okay, so fluids are coming out. And it's usually high-yielding questions that the patient who has opioid withdrawal, they have yawning. And how do you treat it? By buprenorphine or methadone, which are, weak opioid agonists or partial agonists, in order to not give you the full opioid effect, but to reduce the adverse effects. All right, so this is regarding opioids. Next up is stimulants. Stimulants, main one here is cocaine, mentioned in your slides. Cocaine increases dopamine and your catecholamines, norepinephrine, dopamine, catecholamines. It's a stimulant, so it causes increased sympathetic nervous system activity. I put this picture here to remember, in the cocaine, mostly it's taken by sniffing. And this is important because since it's being sniffed, it has key features are red nasal mucosa, nasal mucosal trauma, or very severe. If it was very severe, you have nasal septal perforation. Okay? Remember earlier we mentioned tactile hallucinations with cocaine. Now, the sympathetic overdrive here, sympathetic activity, would lead to the sympathetic symptoms of hypertension, tachycardia, dilated pupil, anxiety, palpitations, tremor, or vasospasm, which could lead to heart attacks and strokes. So this is a really important cause of death in cocaine. That's why it's not good. It causes you to have decreased appetite, decreased need for sleep. Next up is methamphetamine. The key feature is meth mouth. So someone comes in with terrible teeth and terrible mouth. This is most likely methamphetamine. Methamphetamine is basically causes releasing of the stored cholamines and inhibiting reuptake. So it's a sympathetic activity, sympathetic stimulant. Now hallucinations. Now this one is the cannabis or your marijuana. All right, so you smoke marijuana. Marijuana, once it's smoked, it has the key feature here is your euphoria. So people who smoke marijuana, they feel that they're high, they feel that they're happy, they feel nothing, you feel happy, they go crazy in their mind. They feel happy and sedated. They have increased appetite, sedated and slow reflexes. And the key feature here is the red eyes. In exams, they might say conjunctival injection, conjunctiva of the eye injected or redness. So the key feature is red eye. This is the key feature of cannabis or marijuana use. Now, exam question that you might get is what is the active substance in marijuana that leads to the symptoms? Tetrahydrocannabinol, THC, also called dornabinol. It's a medication. What is this here? It's saying in your slide, it's mentioned that sometimes marijuana can be used for medical benefit. But it's not, people don't use marijuana really for medical benefit. They use it for drugs. So, but I just mentioned it for the sake of completion, or you can read it here. All right, so patient here with marijuana, he gets this amotivational syndrome. He's sedated, amotivation. He just wants to sit. He wants more. He's stoned. He's in euphoria. Red eye is key clue. And the amotivational syndrome, relaxed, careless, and increased appetite. Okay. All right. So MCQs review. All right. So that concludes the slides here. This is the review session. Now, what I will do is that I will go over your review lectures that the doctor gave you. So we'll go over the MCQs to see if we discussed them and if there's anything to explain over them, just for the sake of completion for your exam. So we'll do that in a second. Right, so there's two review sessions. This one, which is the 70 slides, part one. The other one is 190 slides. So for the sake of time, I'm not going to go over it. But if you have any questions in that lecture, do feel free to send me the questions and feel free to ask me anything that you have, okay? Whether in my lectures or in the other lectures, I can help you with any part of it, okay? Even in any of neurology, inshallah, if I knew what was going on. But okay, so anyways, let's go over this lecture here because it's the shorter one and we'll go over the question. And if you have questions for the other one, let me know. So okay, so here basically this is a borderline person. We said that he has emotional instability and the fear of abandonment in relationship with impulsive behavior and suicidal use, reckless behavior, reckless driving. Histrionic, he wants the attention, dramatically. Narcissistic, everyone should care about me. Orbital prefrontal cortex, insomnia, poor hygiene or other stuff, poor sleep hygiene. OSA, obstructed pathway of sleeping, lead to snoring and headache in the morning. So this is normal breathing. Physical symptoms, hypertension. See, hypertension is in red. The key symptom is hypertension. CPAP opens up the airways. That's how it's treated. So CPAP is the first line. Sleep paralysis, REM sleep disorder. Usually when you're dreaming in your nightmares, you should not move. REM sleep disorder is that you're moving. Narcolepsy, when you have this hypnagogic, hypnopomping hallucinations. Okay. No orexin, hypocretin orexin is lost in narcolepsy. Okay, hippocampus is for the memory, amygdala is for the emotions, dopamine is for your reward pathway, reward system is dopamine, secreting dopamine. Okay, alcohol withdrawal, more than 48 hours, delirium tremens, less than 48 hours, not delirium tremens. See, this picture here, you might not focus on it, but now that you know, this is a hospitalized patient, that's when he developed his symptoms. Because, he's an alcoholic, maybe you don't know he's alcoholic, but once he has been hospitalized, undiagnosed alcoholic may begin delirium tremens after hospitalization, or stages or procedure, because they don't have access to alcohol anymore. So you must treat them with benzos. And thiamine, don't forget thiamine. Thiamine, then glucose. Alcohol withdrawal timeline, complications, Korsakoff, Wernicke's, cardiovascular. Okay, mammillary bodies atrophied, atrophy of the mammillary bodies. Marijuana, cannabis. Remember, the most important symptom here was the substance is the THC. THC, تمام. Now CBD here is the cannabinoid, which is basically the medical cannabis used for treatments and whatever, but don't really need to worry about that. Red eyes. Did they have mention of red eyes for cannabis? Yeah, see, red eyes. This patient here has red eyes. This is the key clue for cannabis. And he feels stoned. Purging type anorexia, low BMI, less than 18.5, anorexic. Refeeding, hypophosphatemia leads to arrhythmia. Bulimia is low BMI. BMI is normal. Okay, so the BMI is your key difference. Binge eating, they don't do anything about it. They don't care. Okay, psychosis, neurotoxic, antipsychotics, first generation, second generation, negative and positive symptoms. All right, so here, a patient comes in here with minimal physical symptoms, but he's worrying of a serious illness. So worrying of serious illness such as cancer, illness, anxiety disorder. Somatic symptom disorder, he has symptoms. Generalized anxiety, worrying about life. Panic disorder, panic attacks. A man comes in here checking, he fears sudden cardiac death, so he's worrying about symptoms again, illness, anxiety disorder. A patient comes in here, repetitive thoughts to reduce the anxiety. She avoids being alone with the child. So she has these thoughts to harm her child. To alleviate the anxiety, she avoids being with the child. So she has OCD because she does not want them. They don't agree with her thoughts. So these are ego dystonic. They spend hours mentally repeating phrases to prevent harm from coming to family members. So basically, this person here has mental. This person is trying to prevent harm. So it doesn't tell you this clue, but you can figure it out that the patient has these thoughts that to harm the family. So they have these repetitive phases. So the obsessive thoughts to harm the family. So you have the compulsions or the actions to not harm them. So this is the OCD. Ego dystonic. Patient worrying about diseases, including cancer, but worries about finances. See, now he's worrying about everything. What is this? Generalized anxiety. As the person, if you lock the door, returns home multiple times to check. Ego dystonic, OCD. 50-year-old man worries about bodily sensations, occasional headaches. He will the symptoms they present. So the patient has some symptoms, and then he thinks that they are some problem. So a patient here has symptoms, okay? And think that there's some problem. So you have to go to the hospital to check them, somatic symptom disorder. And if he wants to help you more, he says he does tests and everything is negative, okay? All right. Now, why this is not illness anxiety? Because the patient here, he has some actual symptoms. He has headaches and so on. All right. So this person here, so the answer is OCD, hand watching rituals. Person here has worry about everything in life, family, finances, future, generalized anxiety disorder. So generalized anxiety, chronic worry about everything. Panic disorder is panic attacks. Okay, recurrent panic attacks is panic disorder. Key clue: panic attacks, tachycardia, palpitation, sweating. OCD, obsession and compulsion. Illness, anxiety, fear of illness. Anxiety differential, somatic symptom, OCD, general anxiety, as we mentioned them. This woman here she's convinced she has cancer despite everything has been doing normal. She paid to seek medical assurance. She has no symptoms in this anxiety disorder. Symptoms of generalized anxiety must be persistent for at least 6 months. So this is DSM criteria for GAD, 6 months. Which is one symptom most commonly seen with generalized anxiety disorder, A, B, C, and E, which is anxiety, worry, stress. You don't have psychosis, so that's why not D. Okay. All right. So with that being said, let's go back to our slides. All right. So back to our slides now. Now with that, so we can conclude now. The other review session, I highly recommend you guys go over it, do the questions at least, just do the MCQs. If you have any questions regarding any of the psychiatry, this one or previous one, or anything in neurology, do let me know. So my phone number, I didn't think I included the slides, so you can text me. Okay, so do text me if you have any questions in your for your exam or psychiatry specifically. All right, so I wish you all the best of luck, and thank you everyone. Have a good day.